Okay. Admit, see waiting room, 4 participants. Roberta Smith is in the meeting. Five people are waiting. I don't see share at all. Join audio. Now I'm on my headphones, so let me see. Join audio. Share screen. Okay, I'm going to admit all. Joining. And suddenly I see share. Okay. I don't know if anybody sees me. Okay. Oh, I see one person. Can anyone hear? But you're hearing me through the phone.
Correct.
Okay, I see share on my screen. Okay. All right, does anyone see me?
I don't see you yet.
Here's my video. There I am. I'm this ear Roberta, this ear the Zoom where it happens.
All right.
Now, so you're in a different place, Roberta. You should go in through your link then. All right. I am going to take off my headphones because they look really stupid. Okay, you guys can hear me, right?
Yes.
Roberta, can you make this? Oh, you know what? I come up as Roberta.
Oh.
So you
Okay,
can sign in as me.
Hey,
Okay.
Anna.
I'm gonna say goodbye to you, Roberta. Okay, call me if you need me. All right, everyone, we're working hard to get this up and running. You're all very early, you know. We're not that good. I was gonna go up and dye my hair. No, my glasses.
So, Dr. Piccoli, if you are in there as Roberta, do you see where you can start the recording? Because we do want to record it for everyone who can't be on.
It says it's already recording from where I'm sitting.
It looks like it's already recording.
Oh, good. Perfect.
Okay. Still no Roberta. So I would say in advance that we're not allowed to use Zoom at the hospital because of the security issues. I have never driven because of the security issue. I have never driven And yet I'm the driver here. And so, first of all, I think everyone needs to go on mute for a second so that we make sure that there is no feedback. And we really do need Roberta. Oh, I can admit Roberta now.
That's excellent.
So now the only thing is I'm hearing feedback that's like a second later. Oh, it might have just gone away. Oh,
If you
it
want
didn't.
to, do you have everyone muted? You can mute everyone on your end. And then if someone
Mute
raises their
all.
hand, you can unmute them.
Okay, let's see if that works. That sounds like maybe it worked. Will the person that I muted who was feeding back raise their hand? Roberta? Hey Siri, call Roberta Smith mobile.
Calling Roberta Smith mobile.
Can you hear me? I'm in the meeting.
Oh,
Can you hear me?
yes.
Can you see me? Can you hear me?
You're not on the screen.
Okay, I can see you.
I see you when you're talking.
Oh, when I talk. Okay.
Yeah.
Okay. Can you see me,
I think you're
Dr.
good.
Piccoli?
Oh, I do. You've popped on. Yes.
I'm very pink.
Yes.
Okay. I have to because I can't see. There. Oh, I see people now. I see Pastor Chad. Hi, Pastor Chad. Jillian. Hi. See Sharon. And Tad Davis. Hi, guys. Courtney. Hi, Courtney. George. But that doesn't look like George. Villanueva family. Hi, guys. Sergio. Hi, Sergio. Anna Gafford is here. The Palancheck crew. Woo-hoo. Kelly, Veronica Byers. Great. We have a good group here, you guys. So we'll wait. We've got 4 more minutes until 7, so we'll wait just a few more minutes. We'll see who else comes in. Are people still in the waiting room, Dr. Piccoli?
Oh, yes. I guess that's my responsibility, huh?
You're the host now.
Dr. Piccoli, I'm coming in on my app because it's not working too well on my computer. If you could let me in.
Okay.
Let's see who else popped in. Natalia is here. Hi, Natalia.
Hi. My mom is coming.
Tell her you're on a very, very busy conference call. There's Julia.
Oh, hi.
Hi.
I'm
Stephanie
Kevin.
is trying to pop in.
Okay.
Now I'm here and unmuted.
There's Stephanie. Okay. Jen. We've got Maggie Olette. Jessica Brower. Hi, you guys. Wazalski. Phil Neininger. Hi, Phil. See who else. Oh, they're loading in now, Dr. Piccoli.
I'm doing a better job.
Marcia Cocat, she's in Brazil. You know Marcia, Dr. Piccoli,
Mm-hmm.
too. Who else do we have? Amy Fuentes. Paige Malavicas. Okay.
Hello.
Dr. Piccoli, do you still have those questions up? Or
I do not.
Okay, let me pull those up.
We are recording, Natalia.
And Jen, which Jen is that? We have Mom's iPhone. Who's Mom's iPhone? Oh, Ben, there's Ben. He's the reason we're having this whole meeting. Okay.
Hi, everybody.
Clearly, you're a popular guy.
Now, we've now been doing so much video discussion and teleconferencing. We're on about 8 different platforms now. And the switching from one to the other is just maddening for us. And then you have people whose microphone won't turn on, or people who have their video on, but they really shouldn't. We're all learning a lot, and our division just had a meeting, and about 10 minutes of the discussion is what are you wearing below the video screen, which was more than someone of my age needed to hear about.
Funny. Is there anybody else knocking to get in?
Every second someone else is coming in.
We're gonna have to take little breaks and have you check it.
Yeah, you'll have to remind me, because it's not a major part of my screen here.
Okay. Okay, so we'll do one last check and then we'll get going. Tell me when you're ready with the last check.
Me?
Yep.
We're good.
Okay. Hi, guys. Thank you so much for coming on. It's so exciting. Thank you, Dr. Piccoli, for this totally last minute, winging it Zoom having to do with Alagille and COVID. Everyone, this is Dr. Piccoli, and I'll let you introduce yourself.
David Piccoli. I'm at the Children's Hospital of Philadelphia. I'm the chief of the division of gastroenterology. What I am not is an infectious disease physician. the head of the liver center at CHOP, and I've been involved in Alagille Syndrome and Alagille research for more than 30 years now. And I think this is marvelous that we can all get together like this. It's a shame in some ways that it's about a terrible virus, but I'm wondering why we can't do things like this more frequently to talk about all the other challenges that face us. And we in our hospital, and we're in Philadelphia, it's not New York, but it's a pretty active city for coronavirus right now. We've moved almost everything to social distancing, including a huge number of office visits. My division does a little bit over 1,000 telehealth visits a week right now, and we're still ramping up. And I'm amazed at how good this is. I have 3 kids, and my kids have never allowed me to be on FaceTime. We don't we don't FaceTime, we don't Facebook, we don't Skype, any of those things. And yet it works so incredibly well, and we can do most everything that we need to do this way. And I think we're amazed that these telehealth visits, we can't really feel the spleen, but we can do a lot of really important things. And we are open for patients who need to come in. But I wonder why we just don't have more of these kind of national, international discussions of things. They're really pretty easy.
Well, I think we probably will now. Now that we got you, we're gonna lock you into a couple more dates. How about that?
Yeah.
Well, I just want to say that the topic of this Zoom is really about Alagille and COVID, and I'm gonna let Ben Teitelbaum take it over for just a minute and introduce himself, and then he can get the ball rolling on the questions. So really what we want to do is ask some questions, give, and we want to answer as many questions as we can tonight, and it is recorded, so everybody can have the recording, and we can kind of share that recording on social media as well. And, Dr. Piccoli is very open to taking residual questions as well, so I'll email him other questions after the Zoom, and he can certainly answer those, and we'll provide answers on the awareness page, and maybe we can schedule another one as well. And absolutely, it does not have to just be about COVID. We did start a Zoom meeting weekly that we've had 3 of those now, just with the Alliance and families. So everyone be aware of that, watch for those links as well. And as we continue to grow that program, Dr. Piccoli maybe just can jump in on some of those too, when the time is right for him. So, all right, Ben, I'm letting you take the floor.
Okay, well, thank you, Roberta, and thank you so much, Dr. Piccoli, for taking this time for us. I suppose I don't have anything prepared, Roberta, other than to describe maybe the interest that I had in wanting to put this together. It was really 2 things as I'm thinking about my own family, and that is,
I can read it word for word if you want.
Oh, my questions that I posed?
Yep. Yes.
Let's go with that. I like that better.
You said, we have heard that heart, pulmonary, and even liver disease increases the risk for COVID patients, but youth has reduced risk. What should younger ALGS families make of that? Along with that, given that we are likely to see phased reintegration in various spots around the world, and with the most vulnerable being reintegrated last or waiting for a vaccine, what do Alagille families think of that, or need to think of, and how will the outbreak impact ongoing research on ALGS?
That's a great question. It's like 6 questions.
It is.
The first thing that is, I would say, so many of the things that we'll discuss are probably true until someone proves them not quite to be true. So many of the things that we heard before this disease came to the States were different than what happened as it started to permeate through the states. And as we're learning more and more, we continue to evolve. And so you can see things that say one thing and things that say another thing. And even within our hospital, we've changed week by week on what we can do and what we think about it. So first of all, the one thing that is clearly true is that younger patients do not get as sick as older patients. So in our hospital, which is an extremely large hospital in a city where coronavirus is quite active now, we really average between 4 and 10 inpatients a day. And of course, they stay for multiple days. So we're diagnosing 3, 4, 5 new cases a day. And the majority of the children are barely ill, and some are not ill at all. And so that has a couple of different implications. So first of all, for your children, they might do better than you, and certainly better than the grandparents. The second thing, though, which is really difficult from a pediatric hospital point of view, is that because many of the children that we see might have diarrhea or a fever with no cough, or a cough with no fever, they don't follow any of the rules that you kind of see when you're looking on the web at websites about what does this cause. And so we feel as though we have been at and continue to be at significant risk from children who are shedding virus but who don't really appear to have classic symptoms. So we have gone to a strategy of doing the testing for every single child who's admitted to the hospital, so that we have a good idea about who is at high risk, who do you need to have higher level precautions for. And we were lucky and prepared, because a very long time ago, we developed testing for COVID-19, for coronavirus. We were the first hospital in the state of Pennsylvania to have it. And right now we have the capacity to do probably 3 times as many tests as we need to do. And we have a turnaround time of 4 or 5 hours. So that's very different in different parts of the country. And what you can do and how you manage the patients that you have and what you can do depends very much on, do you know who's actually sick, and do you know who's been exposed to them? So we have exposed a large number of adults in our hospital. Some of those adults have become fairly sick, but for the most part, the children do well. So then the second part of Ben's question, we're very concerned about people who have lung disease. And so at one end of the spectrum, some lung disease is in the airway sacs, and some lung disease, particularly Alagille syndrome, is in the arteries or the blood distribution. And patients with cardiac disease have some combination of those things. So we do believe that you need to be very careful. And we think, at least theoretically, that having cardiopulmonary disease increases the risk at whatever age you're at. But if you're a very young patient, that baseline risk is probably pretty low, which is not, any of these things is not to say it's okay to get this. It's very clear that we all would be better off if we didn't get it at all, or if we got it after we identified, some therapies for it, some prevention for it. And we can talk about those a little bit and what those might look like. So we think that there's at least a theoretical increased risk. For the people who have been transplanted, we know that there are a large number of viruses and other infections that are significantly worse if you've been transplanted because of the medications that you're on. It is not so clear that coronavirus is significantly worse for patients who have been transplanted. If you look on the Transplant Society website, it's all about warnings for transplant patients with coronavirus, and that's appropriate. Certainly you don't want another problem, but there's some preliminary evidence that some of the different immunological and immunoregulatory disorders are surprisingly not so much more susceptible to coronavirus, where they might be significantly more susceptible to things ranging from adenovirus, other infectious viruses, and so on. I wouldn't, at this point, look at that data that says maybe it's not so bad and relax. But on the other hand, it isn't that getting infected with these viruses as a child is going to be fatal. That's not the way that this has been happening so far. Although the bottom line really here is we just don't know. Someone asked the question, you know, how has this virus been for Alagille syndrome? And at least where we are, we don't know of an Alagille patient who has been infected. It will happen, and depending on how this reintegration into a somewhat more normal life, there are different models that suggest that, you know, many Americans are going to get coronavirus before we have a vaccine. So we will get more information about it, but right now, for the patients who don't have severe cardiopulmonary disease, it seems like the risk is probably about standard, at least theoretically, and much better for children than for adults. It's pretty clear that if you are, you know, over, and you could pick the age, but the risk keeps going up and up by the time you get into your 60s. If you have diabetes or other comorbidities, you know, the mortality is substantially higher. Again, we don't really know the number because as people are starting to do other kinds of testing, it turns out that there's a surprising number of people who have been infected and didn't really know it. So that makes the relative mortality look less. If you only look at sick people, then sick people do kind of badly. But if you look at a whole population, including a lot of people who are not sick, then it doesn't seem as bad for each individual infection. But the statistics are the statistics. A huge number of people in North America have died from this infection, regardless of whether or not a huge number of people also had it and didn't really even know it. And that's something that we're just starting to be able to look at with antibody testing. 4 months from now, we'll have a better idea about that. As far as research goes, we're under strict orders to shut down all of our research. And that goes for Alagille, it goes for inflammatory bowel disease and everything else. We've closed all of our labs except for the people who go in to keep cell lines alive or to keep some of the animal lines alive. Our research assistants are home and we're trying to figure out what to do with them. In some places, they've been furloughed. People are a little bit going crazy. For the clinicians, we can do telemedicine, we can do other things, but for the people who are bench researchers, they really just kind of have been locked out. So this puts things on a hiatus. Our CEO this week went to our governor, who, we're recording this, right? He's a great governor. Hi, Gov. But, you know, we're under mandatory shutdown for a lot of things. We're not allowed to do standard risk procedures right now. So even though we know we're not infected, we know the patient's not infected, we're not allowed to do an endoscopy or, you know, a monitoring liver biopsy. And it's been very hard for a few of the research studies that have definitive time points where you're supposed to collect data, and you're collecting that data because it's a time point, not because it's urgent. And so, you know, I think of all the different things we do, research has been tremendously interrupted by this. At the political, social level, it's not that people couldn't be doing this, but it's considered a non-essential business by the people who make the rules. Did I miss anything, Ben? Okay. Next question, Roberta.
And I do want to piggyback on that. That is the case also for other scientists working in Alagille as well. Duke
Yep.
Dong at SBP, their lab is shut down. You know, many. Sanford Research is shut down right now. So across the board, anyone working in a lab is really, they're furloughed. That is frustrating for us as an organization, but also, you know, we've heard from the researchers, and it's extremely frustrating for them as well, because they have some novel, significant science that they want to get to, and they're putting them on hold. So we're hoping that, you know, as everyone is starting to get reintegrated, that, you know, the labs are a priority for this research, for sure. So that's a great question, Ben. One thing that keeps coming up, also, Dr. Piccoli, is, just had it sitting here, you know, post-transplant. You talked a little bit about post-transplant, but the immunocompromised does, you know, a lot of our families still are going to appointments. They're going to appointments for post-transplant. They're doing labs. Has CHOP moved to telemed? Have you seen the majority of the hospitals moving to telemed? And what do our families need to be aware of as they're continuing to go into the hospital and have these appointments?
So those are all good questions. And I think the most important thing, whether you're going into the hospital or, you know, into the supermarket, is to, you know, protect yourself as best you can. So we started fairly early the division. So my division has about 70 practitioners, physicians, physician assistants, and advanced practice nurses who do GI and liver. We, right off the bat, canceled 3,000 outpatient visits. And we stratified them into two groups: the people who had to be seen and the people who could be postponed a little bit. And we have someone who is low risk and high tolerance in at every one of our satellites to see all of the higher level cases that need to be touched and seen. And so for the first week, we sat around and were going crazy, because although our hospital, like most hospitals, have talked about telemedicine for the last 3 or 4 years, nobody's really done anything particularly effective. And so we went from, in our institution, we see about 1.4 million outpatient visits a year. We were doing like 1, 2, 3 televisits a day for the entire enterprise. And then all of a sudden it was 300, 1,000, 5,000, 8,000. And in our division, GI at CHOP is leading in the telehealth field. We are twice as big as any other division in televisits, and we're doing about 1,000 a week, a little bit more than that now. We crashed the system, we crashed the servers, we went past the number of licenses that we have, we destroyed the bandwidth, we ruined one whole VPN server center. It was a mess, and every 2 days, it was another problem. We're finally at the point where we can do telehealth, and it works, and we're doing new patients now, we're doing second opinions, because we do fully believe that the fewer people are in a room at one time, the more likely we are to get in control of this virus. So I haven't seen most of my faculty members for a month now, except on a screen. We went very aggressively after personal protective equipment, the PPE. And, you know, before coronavirus, every scope, I'd wear a new mask, take it off, take the gown off. We're used to that, you know, clean at each, you know, event sort of thing. As we started to ramp up, I got one mask of the regular kind and one mask of the N95 kind for a week. And we are recycling the N95s now. Everyone in our hospital, from housekeeping to CEO, wears a mask when we're in any patient areas or any transit areas. And I wear that mask for a week. We're starting to relax that now, but we thought the next most important thing was we would put masks on the patients. We have a lot of rules that make sense that are anti-pediatric. We only allow one parent to come with their kid. We do not allow any other children for the visits. If you come from a high-risk area, we were cordoning you off and you couldn't go to the cafeteria. We would deliver food to you, but wouldn't let you track around. If you're a parent of a coronavirus positive patient, you can't leave the room under any circumstance. You get a private room, that's the good news, private bathroom, but you can't go anywhere, you can't do anything. And the parents can't swap in and out. You have to pick one. But those are all things that we did to control things. The non-liver side of my group is endoscopy, and some of you have had endoscopy to look for things like varices or other digestive things. It turns out that endoscopy, ENT, anesthesia, ophthalmology are extraordinarily high risk events because they spray this virus all throughout the OR. And it's not this 6-foot containment, but these are aerosolized, so they go everywhere. So everyone in the OR cases needs to be N95 protected. And then we were like that for 2 weeks. And then it turned out that we are able to test everybody who's going to have a procedure just before the procedure, get the results. The results are pretty accurate. They're not perfect. And so we've been able to save some PPE and be a little bit more judicious about it. We did, I think for many of you, you know, fellows and residents on the inpatient side, we stopped our fellows from doing any procedures because it was one extra gown, one extra exposure. And while we might have 60 faculty members, we only have 15 fellows. And if all those fellows get together and get sick, we're kind of like dead in the water. So we separated them and we limited their exposure significantly. We're moving forward, and I think we feel supply lines for PPE were pretty decent, but there are horror stories across the country. One of my friends from high school from 50 years ago sent me 2,500 N95 masks. Just happened to have a way of getting them. It was pretty incredible. I had to pay $500 shipping, but compared to what they cost on the open market, that's a deal. You may have heard like the governor of Maryland's wife just contracted for like 500,000 masks from Korea. I think people are struggling, and I think it's important, I believe, important for everyone to wear a mask. I go to senior citizens hour at the supermarket at 6 a.m. We're all wearing masks. Everybody's like, the aisles are one way. I assume that's true for a lot of you, maybe not all of you. So we don't have our kids come in for visits right now unless they have to have blood drawn. We think having blood drawn in our institution is safer than going to one of the laboratories out in the community that draw blood. We've cordoned off people who are high risk. So we're now very afraid of people who come from New York. Not afraid, but cautious. So they go to a separate place in the hospital for their outpatient visits. We have special precautions for that. We have a phase 1, phase 2 sequence where we're opening up. We're still in phase 1 in our hospital's mind. Everything has to be emergency. It has to be careful. And I think that's how people need to be at home right now. You know, you can't let the kids next door come in and play. We're all going crazy. But you know, this virus will starve if we get 2 life cycles where people don't infect each other. You know, it needs to jump from person to person. And so, you know, we're trying very hard. The mask is not perfect in protecting you, but it makes you less likely to be putting virus out to hit someone else. So it has 2 purposes. And I think, you know, a bandana, we would never use a bandana to protect ourselves from a patient who is positive, but it does stop you from spreading things outward. I think the good thing for us, and again, we have this luxury, is anybody who thinks they're even possibly sick, they stay home, they get tested. Right in the beginning, 14 people in my division were exposed. And so they had to be quarantined for 14 days. Well, you knock all those people out of the care delivery sequence, you can't survive if that keeps happening. But right at that time, we got good quality testing. And, you know, everyone who has an allergy, everyone who has a little cough, everyone who, you know, has a hot flash, everyone's, you know, like, oh my God, I have it. And it's great to be able to do the testing and say, relax, you don't have it. And that has helped us control things a lot.
We have a couple questions, Dr. Piccoli, but I do check the waiting room, see if anybody's in there.
Nobody waiting.
Oh, Jillian, do you want to ask your question? And then Tad Davis has a question after Jillian. And if you would introduce yourself and where you're from and where you're treated.
You're still muted, Jillian.
You're muted.
Just kidding. Hi, everybody. My name is Jillian. This is my husband, Pablo. Our son, Aiden, has been diagnosed with Alagille. We are located in Miami, Florida, and we are currently being treated by the Miami transplant team, as well as gastroenterologists at Miami Children's and former Jackson gastroenterologists. Our son has obviously not been seen by his physicians. He has a slew of treating physicians, from feeding therapy, for his G-tube to not eating, but recently our issues have been with the pruritus and his itching. It has gotten to a level of uncomfortability. He's waking up 5-6 times a night. The scratch is just out of control. That's him. He's currently on rifampin and Atarax twice a day. But it's just not seeming to work. So we have discussed with our gastroenterologist and the transplant team where we're at, and they don't have an answer, and understandably so, because they can't see him They can't draw more labs. On his last set of labs, his bile acids were at 137, but his total bili was a 0.08. So while the liver is functioning, the bile acids are obviously sticking around and making his life a nightmare. So I guess my question is, you know, is there other medications that maybe you're utilizing up in CHOP that, you know, we can go to the transplant team and say, hey, this is what's on the table. Would this be appropriate for him?
So the answer is definitely yes. I don't know if you have the DVD that we made with the Alliance. People use different styles of therapy for the itching. I would say that at his age, if the bilirubin is less than 1, that's a great sign long term, particularly if you've seen that it's been coming down a little bit slowly over time. And do you know what his cholesterol is?
I do not.
Yeah. So we would rifampin at a good dose, ursodeoxycholic acid at a good dose. We use hydroxyzine only 1 dose at night, a little bit bigger dose to get sleep. We find that in some patients, if you use it round the clock, it doesn't seem to work as well. We use the opioid blocker, which is a great medication, but because it comes like in an adult dose, you end up cutting it with a razor blade into very small doses. And for someone who excretes bilirubin well, Questran or cholestyramine can be a major plus. And so some combination of those are likely to make life good enough. And if you follow the bile acids, you can tell, is he worsening or is he actually getting better? But that bilirubin is an optimistic sign, and it says that you should be able to get in better control of his symptoms.
And Jillian, we'll have a recording, so you'll be able to go back and listen to all the meds again.
Great.
Okay.
Thank you.
And speaking of that, Dr. Piccoli, as they can't get in right now, is this a good time with the telehealth going on to get second opinions, because almost everyone's going telehealth?
Yeah, I think you can do with the records. I think you can do a really good job with telehealth right now. It's not quite the same as feeling the belly, but usually the first person who has seen you has done a good job, done a good physical exam. You can tell a number of things from the labs and from the record and from the biopsies. And so, I think that we're all learning. 2 weeks ago, our attendings kind of said, we're not doing any second opinions because you don't get to touch the patient, you don't get to look people in the eye, you don't really get the sense of what's going on in all of those other clues. And then last week, we said, there are too many second opinions piling up, we're going to do second opinions. This week, people have said, we can mostly do second opinions fine, and if we need to have somebody come in and be seen in the office, we'll do it in June when the risk is lower. So I think a lot of places are progressively extending. 6 months ago, the idea that you would do a new patient visit without touching a patient, no one would have agreed to that. Now, necessity is the mother of invention, or whatever. We've all expanded our ability to do things. I saw something actually from Florida where not Miami, where a gastroenterologist sent around that he can do a 13-point physical exam in a telehealth visit. And one of them, he has the parent press on the abdomen and decide if the abdomen is tender. I thought it was creative.
Yeah.
But I don't trust my fellows to feel a spleen. For the people who know me, I'm like out there with my pen going, here's the spleen, make sure you agree with me, you know. Can't do that, you know, telehealth.
Tad Davis has a question, and Veronica Byers after him.
Hi, I'm Terry Dell, and this is my husband, Tad. We're actually from Arizona. We get treated at Phoenix Children's Hospital. Our son is 8 now, which is awesome. He has severe Alagilles, but in addition to that, he's been diagnosed with juvenile rheumatoid arthritis and is currently on Enbrel. So he does have all the pulmonary issues in the blood flow, which I know make him at risk. But what does the Enbrel also make him more at risk, where we need to be more careful, or like how does that play?
So I think everyone needs to be more careful, everyone, but theoretically at least, Enbrel is an immunomodulator, so you would be more careful than more careful. There are at least one, if not two, other parents on this list who have significant joint disease that acts like JRA, and that's something that I think is really very interesting to us, and we might try to get a couple of the families together to compare notes and try to figure out what is going on with that. I mean, strictly speaking, that's not an association that we would expect, but it's clearly an association that happens.
Veronica?
Thank you.
Hi, Dr. Piccoli. It's Veronica, Charlotte's aunt. How are you?
Oh, good. How are you?
I'm good. I'm hanging in there. So, I'm glad to see you, and thanks so much for doing this. I always feel so much better talking to you. So, you know, we're in a high-risk area up here in New York, and my biggest concern is accepting packages from the outside. I know there's like debate on how long it lives on certain surfaces. So what is your opinion on takeout food and you know, accepting packages from Amazon and medicines from everywhere? What is your opinion on that?
Yeah, so my opinion is only as valuable as anyone's who has been listening to the news. Initially, it was felt large droplet, couple of feet, you know, distance, and then it was clear that it sits on surfaces sometimes for hours, and then it sits on some surfaces for longer than that, maybe plastic and steel. And so, you know, I believe that, you know, you get something, you open it up, and then you go and wash your hands for 2 happy birthdays, you know, or some people do, you know, hot-blooded, whatever is your song to make you, you know, wash. It's not a zero risk. It's not as much of a risk. The fact that you can detect viral nucleic acid on something a day later doesn't necessarily mean that it's infectious particles. But I think we have to be careful. The question of who prepares your food is a really complicated question that hasn't yet been solved. But it's very clear that you don't have control of that prepared food that's coming in. You know, why is it that one of the hotspots are grocery workers? You know, and we don't know some of those answers. But if you have your food prepared and brought in, you hope that the people doing that are not doing it when they're sick. And, you know, for me, of a certain age, I've cooked for my dear son who lives with me for, you know, the last 5 weeks. I also shopped for him, which is quite a deal. And, you know, I think you have to be really careful, and we really just don't know You know, you notice now that all the people who are delivering are wearing gloves, and that's good at one level, but if they wear a glove and they touch their face, there's stuff on the outside of the glove. I think a glove and a mask reminds you that your face and your hand shouldn't touch each other. But they're not full protection if you're wearing them all day long. So I think you have to be careful. You know, it's not like, you know, don't leave it outside for a day. It's not like that. But I think you have to wash your hands and, you know, be careful.
Jennifer Aponte, and then Anna Gafford, and then Joanna Palanchek.
Oh, we have to turn you on, Jennifer. Hold on, let me see if I can do it. Yes.
Is there anyone trying to get in, Dr.?
Thank you, Dr.
Oh, there
Piccoli.
is. Thank you. All right, Jennifer, you're on.
My question is, I have an 8-year-old who is severely asthmatic. You were talking about how, you know, the children seem to be at lesser risk or get less of the disease or a milder form. Is that regardless of any comorbidities that they may have, or, you know, are there certain conditions that make them more vulnerable to get sicker with this disease? Or
Yeah, it's a great question, and I think I'm going to give you 2 answers. I saw one study that said there is not increased risk in asthma. I read it, I looked at it, but when you have pulmonary disease and you have a virus that makes inflammation, it's hard for me to believe that there's not increased risk, because asthma, fluid in the airways is a part of asthma, and fluid in the airways is part of coronavirus. I would say be more and more careful. There clearly are other minor viruses that make asthmatics terribly sick. So I would say super careful.
okay, thank you.
Who's next?
Anna Gafford?
Hi. So my question was just with the antibody testing that is starting to come available. As that reliable testing comes available, which I have not found a place in San Antonio yet, I don't think we're quite caught up, but what does that mean? If you test positive for antibodies, you test negative for a current infection, does that mean we're safe to be around other people? Does that mean we are safer around other perhaps unknown infections? Were we essentially self-vaccinated at that point?
Great questions. 1, 2, 3, 4, 5. So the usual testing looks for nucleic acid. It mostly marks active infections, and that testing can be done pretty reliably, and the results can come back very quickly. And this is the testing that most people are getting to determine whether they have it in the current state. A problem is that because we don't have a national lab, a national standard, different places, I mean, we developed our own test. We've never used a state lab. We think that ours is very accurate, but we have like a 5% test rate every day where we're not sure what it means and we repeat it. So that's number one. That's sort of what people call the PCR testing. So antibody testing is very different. It looks for the immune response of the person to whether they have seen something that looks like coronavirus or that they've seen coronavirus itself. And so there are some diseases where you make antibody, but the antibody doesn't equate with being cured. So for instance, in hepatitis B and hepatitis C, you can have some kinds of antibody and still have active virus. So that's one thing. The second thing is that there are different types of antibody response. There's an IgM, and that is the early antibody that we make to something. And then there's IgG. And IgG usually, but not in those two kinds of hepatitis that I talked about, usually means that you've developed an immune response and you are probably immune. So if you take hepatitis A, we're staying in liver things. Hepatitis A, if you make antibody to hepatitis A and your kids got a shot, but maybe you as an adult got the infection, when you make that antibody, you're done. You'll never get that disease again. If you got the immunization and you got the right sequence, you're not going to get that disease either. If you make antibody to mono or to herpes, that's a different kind of virus. And although you've made antibody, it doesn't stop that disease from reactivating, even from within your own body. And then the third thing is sometimes you have antibody that looks like it's against this thing, but it was made to be against this thing, and it's not high quality antibody. So all of those things being said, the simplistic answer is if you've been infected, you will make antibody. That antibody, we hope, protects you from being reinfected. And then that person who has antibody might be like super valuable for two reasons. One, you can probably go to work wherever, and if this all works out, you are likely not to get infected again. We don't know that 100%, but that's probably true. And secondly, one of the therapies that's now been used, and one that I personally really believe in, and if I get sick, I'm going to want somebody to give me. I don't know if I could get it. I don't know if I have any pull. But if you take antibody from someone who just got done with the infection and you give it to someone who's early in the infection, you can, it seems from the initial studies, change the course of the disease for the better. And there certainly are other diseases where if you give antibody from people who have been infected, you can stop someone from getting a bad infection. So these are the studies that everybody's doing. We're doing it at Penn, they're doing it at Mayo, Cleveland Clinic, Boston. Everybody's doing these studies now because there have been a couple of studies, early studies from China, where they took people who were critically ill, gave them antibody from people who had just recovered, and these people didn't die at the same rate as ventilator patients. So antibody, one of the questions is, how many people in your neighborhood have already been infected and didn't know it? And if that number got up to 30 or 40%, then probably this virus couldn't jump from person to person to person the same way, because some percentage of the people it was jumping onto were immune and weren't going to get sick. So one way that pandemics go away is like the Spanish flu pandemic. Once everybody got infected, then the virus really didn't have anywhere else to go, and so it kind of died out. But it could be a great therapeutic agent, and I think that's what we're hoping for. We're not sure the antibody test that we have is yet proven to be a great test. And I think that's one problem, is most places don't have it. And the second problem is they're not all testing exactly the same thing. And some of those tests will turn out to be lousy, just like some of the initial CDC testing of a different type turned out to be flawed. So we're not there yet, but ultimately that will help us to know, did you have it? I would love to know I had it, because I don't have to worry, I don't have to worry about getting it again.
Yeah. Palinchek. And then Neininger.
So what doctor is Hi, Roberta. Hi, everyone. Roberta, can you
Hi.
read my question? We have a lot of background noise and
Sure.
stuff going on tonight.
Absolutely. Let me find it here. The Palate Check crew, they are down in Florida, Dr. Piccoli, and they're saying, how do we prioritize catching up on routine appointments that have been postponed due to COVID-19? How do we let our healthcare providers know that these routine appointments that we as parents rely on are appointments to ensure that our child is on track and healthy, that we are not missing something that we should have noticed months ago?
Yeah, I think that's a great question. And I think that for most institutions now and most practitioners, you can schedule telehealth video visits and they work. The one group for us where it really doesn't work particularly well is cardiology, because they really need to listen to the heart, get the vitals, sometimes do echoes and EKGs. But I think for the most part, we can do a really pretty good job by video, and I think you should ask who's doing that. Can they do that? And in our own institution, we GI are doing 10 to 20 times as many visits as some of the other divisions in our Department of Pediatrics, just because they didn't ramp it up the same way. But I think everybody is thinking we're going to be in this for months. I think most people think that it's not going to go away just because there's a summer. And so we're preparing that this is going to be the way that we're doing things for a long time. But we will also make it so that if you come into the hospital, we can make it safe. The hospital will not be the riskiest place that you will go. But I think video visits are great. They work most of the time, and they're so much better than just postponing.
Neininger?
Hi, Roberta. Hi, Dr. Piccoli. This is
How you
Christine.
doing?
Good. How are you?
I can't tell which screen you're in here. Oh, there you go. I see you.
Hi. We are from upstate New York and are very fortunate to be treated at CHOP. My son is not a child any longer, but my question is regard to a vaccine once it comes out. Will it be recommended that asymptomatic adults get the vaccine along with post-transplant, or children with active Alagilles receive that vaccine?
Yeah, absolutely. I mean, from our practice point of view, oh, I just touched my forehead, sorry. We always recommend the flu vaccine, that people get their pneumococcal and the other vaccines that protect you. I think when they make an effective vaccine, I think all of us will get in line. I think the worry is that it's really hard to ramp up. Even if you make a great vaccine, it's hard to ramp up to make 3 million doses a year. And, probably to get the country under control, we need more like 30 or 60 million doses. And it won't be clear. Some vaccines, like the cervical cancer Gardasil vaccine, you need multiple doses. Hepatitis B, you need multiple doses. But yeah, the sooner 5 different companies make an effective vaccine, that's probably the most likely way that we'll get out of this pandemic. And some of them may work better than others, but a vaccine can totally change the course of viral history.
Thank you.
Maggie Olette, do you want to read yours, or let's see, I'll read it. How about that? Maggie would like to know, is it safe for ALGS adults with mild cardiac and liver symptoms to be working in a very busy healthcare setting, as in EMS?
It's, I think EMS particularly is a very tough place right now because you will be picking up people who are sick, and even with the best of protective equipment, people with, full face shields and N95s and gowns do sometimes get infected. So I think that you may not be a higher risk than the other person in the ambulance. You might be, you might not be, but that's an area where if you're around people who are infected and coughing, it's really a significantly higher likelihood that you will become infected. I think that's an area where, for instance, if you could get antibody testing and find out that you've already been infected, then you might be golden, because you'd still be protected, but you wouldn't be as much at risk. But I think EMTs, emergency room people who take care of the elderly and assisted living, there's a higher risk of exposure in all of those areas.
We do have some Alagille parents as well that are working in the healthcare field, including myself. And when they come home, we've seen some Alagille parents who are not coming home to their families. They're staying, in an RV or somewhere else. Can you speak to that as well? What are some precautions that the parents may need to take?
Yeah, I think, depending on what your exposure is, that a significant percentage of medical caregivers on the front lines are not going home. And not everybody can sort of cordon themselves off, in a, sorry, I have somebody waiting to be admitted. A basement with a bathroom with food delivery. People maybe have seen like Chris Cuomo, probably has a fair amount of resources and knowledge, and yet his wife got infected anyway after he was locked in the basement. It's really hard. It's a real challenge because you don't want to bring it home to your kids. Nothing, or to your parents, which is even significantly higher risk. My daughter works in the hospital. I haven't been within 6 feet of her in 5 weeks now because she's convinced that I'm old, she's exposed, and she's not going to be responsible. So, I dropped her off some homemade spaghetti sauce. I left it on her front doorstep. And once I drove away, she went out and picked it up. I don't know if she washed off the container before she brought it inside. But, it is, you want to really protect your risk, but, all of our people are home with families. And so you want to, the whole family unit is one, try not to get any of us infected unit as best you can.
Jillian has another question. Jillian Baser.
Yes, can you hear me? All right, and I will apologize for making this kind of like a independent type question. Our son has a major aversion to eating or even putting anything in his mouth. He doesn't put any toys, any food, nothing. So my question is this Alagille related? And if so, what recommendations do you have for us besides therapy, of course?
Yeah, so first of all, I don't know the specific situation, but a number of infants and toddlers do really well with a G-tube, a gastrostomy tube. And it does two things. It allows you to deliver the nutrition that they need so they can grow. And growing is one way to get out of the symptoms. But then, and we have a very large feeding team, a feeding program. And a problem is that when parents feel totally under the gun pressure to get that food in, they make it makes the whole feeding situation markedly worse because you feel like you got to do this last 1 ounce. I'm going to squirt it. Even though this is a glass bottle, I can squeeze it. I can pump that nipple, and it makes it less and less pleasant. So it becomes aversive. And so even if you're 6 or 8 months old, if it hurts to defecate, you don't defecate. If it's unpleasant to eat, you don't eat. And so the G-tube allows you to give the adequate nutrition, and then you go back to trying to eat for joy. And the eating for joy then is a road to success. And that's not specifically Alagille. The specific problem with Alagille is that if the bile acids are, 10-fold elevated, the absorption of calories might be down by 20 or 30%. And so if a normal child needs to eat 100, and Alagille needs to eat 130 to grow, and then it's even more stress and more pressure. So it is a learned aversive event more commonly than anything else, and it happens with a lot of chronic diseases of disordered growth or absorption, and a combination of providing the nutrition around the mouth, and then working with a feeding team to figure out how to make it joyful and positive. And sometimes we use medicines in addition, acid blockers and other things, but a lot of times they don't really do that much, honestly.
And please know, Jillian and Pablo, this is so many Alagille families deal with that, and you guys are not alone. If you were to go into the awareness support group and even just make a comment in there, people will swarm you with, their feelings of, how they've tried to deal with this same situation. So you guys are, I promise you, you're not alone in that. So right now we don't have any more questions lined up in the chat, but how are you doing on time, Dr. Piccoli? It's 8:04. Do you have a little more time left?
I think it's 8:04 here too. Yeah, sure. We can keep going.
So
Roberta, I think there are 2 questions that came in just a minute ago.
Okay.
From Jen Aponte and Anna Gafford.
Okay. Jen, do you want to ask yours, and then Anna again? And then we can just open it up to anything. Doesn't have to be COVID related.
Yes, thank you. Another question, kid severely asthmatic. I have a essential worker in my home. But my question comes to, as they're trying to reopen the nation as we move forward, they've been closing the schools and, they've been home for 5-6 weeks. How should we reintroduce the children to school that are high risk, knowing that children can't social distance to save their life, especially when they've not seen each other in months? So
yeah, I think so. There different people have different philosophies around this. I think if you have the means and the ability to keep your child out of that situation for a while, it's better. But now every neighborhood has a published rate of infection. And so in my neighborhood, 2 things: high infectivity rate, and kids can look fine and shed the virus for 5 days, and yes, they're all over each other. There's no way you can tell a kid not to rub their nose or cough into your elbow or whatever. So I think that to mitigate the risk, keeping kids away from kids, if you can do it, is a good idea, particularly if they're under 6 or 7 years of age. But hopefully we'll get to the point where the incidence level of virus in neighborhoods goes down far enough that the risk is really minimal. It won't be 0 for years.
she's 8. And does this extend into the fall, like for the August semester?
I think
'Cause she's not
everybody
going anywhere now.
believes we'll have a bump in the fall. Not everybody,
Okay.
but a lot of people. Dr. Fauci.
Yep. And the
Thank
lady
you.
with the scarf. She wears the
Yeah.
scarf a lot. Anna Gafford, you have another one. And then we had a question from Sharon.
Yeah, so I just have what's probably a very irrational fear, and so I was just hoping you would provide like facts and logic to combat the irrationalness. And
Uh-oh.
that's just that as we move towards vaccine, like I know my husband's like, I can't wait for vaccine. I'm gonna get it the first day it's available. And I'm like, whoa, whoa, whoa. I feel like if things are rushed, then we miss safeguards as we go through, like with the antibody thing where the FDA was like, hey, we'll relax our standards. And people came out with shoddy, half done kind of stuff. So I had the same concern about, you know, if a vaccine was pushed through quickly, that we would miss checks and balances and have something higher risk. And I would like you to just speak logic into the irrationalness.
No, I think that's really fairly rational. And you know, whenever you treat something, you have to think about the risk of the treatment, the risk of the disease, and the likelihood of getting the disease. And that's kind of a, you know, at the national level, it's a mathematical formula. And if 1 in 10,000 people who get the vaccine die from the vaccine, which would be horrible, but if it prevented the disease in the other people and that saved, you know, 500 deaths, would that be in net a good thing for society, a bad thing for one person? So a lot of medicines that have a great effect for most people can have an allergic reaction. You know, penicillin, you could die from a penicillin reaction. I would be racing your husband to get in line for the first good-looking vaccine that came down the pike. I would actually probably stand back because there are higher risk people than me. But I think that we won't get an unsafe vaccine to come through. And I think vaccination is our way out of this. I would definitely do it. You know, we're in a city where, you know, there was a big measles outbreak and it was horribly fatal. You know, pertussis, other things. Vaccines may not be 100% perfect, but the diseases can really be terrible.
Okay, Sharon, you have a question?
My son is 38 and he's got just been diagnosed with pancytopenia with the low red blood cells, white blood cells, and whatever else is in the blood. And I was just wondering, some of the things that you've said, like my son goes to a community place to get his community agency to get his blood tests done. He goes out into the community. He has carers come in because he's had a stroke, a bit of a stroke. You know, just wondering, should I be doing more towards protecting him?
So depending on which type of pancytopenia, and there's a spectrum from you have low counts because your spleen is huge, to at the other end of the spectrum, aplastic anemia, where you can't make any of the 3 cell lines. He would be at risk for a number of things and would be a person who, first of all, they should know if he can make antibody and he should be immunized. But if he's pancytopenic on this end of the spectrum, he's got a lot of risk for a lot of things that are more important than the coronavirus, and he should definitely be careful about exposures to many things, not just coronavirus.
I just want to say one thing more. I'm from Brisbane, Australia, so it's interesting talking about how you are to how we are.
Yep. And good morning. Ooh.
Okay, we have.
We're letting George in, and
And let's see, Paige has a question, and then Tad and Terry Dell Davis have another question. Are you still okay on time?
me, sure.
Yep. Okay. You just give me like the baseball, you know, codes, hand codes when it's time to go.
I think Paige may want you to ask the question, Roberta.
Okay, let me look. By the way, you guys, the person you hear also
George,
talking.
George, I just unmuted you, so now you can talk.
Thank you for letting me back in.
You also hear Cher Bork in the back. She's kind of talking back and forth with me as well. That is our executive director at the Alagille Syndrome Alliance. You want to?
Hi, everyone.
And then let me see, Paige. Where is she? Okay, Paige says, is a 12-month-old with Alagille considered a higher risk category for contracting COVID versus non-Alagille kids if there are no known respiratory or cardiac issues? Are Alagille patients able to combat the virus and recover as well as non-Alagille babies or kids? Some of that we talked about earlier as well. I rescheduled our GI checkup and echo from this month to May 19th. I was planning to have labs done. Should it be okay to keep this appointment and have an echo done as well? He's increasingly itchy, and I want to ask for new anti-itch medication.
Okay, so those, Paige, there are 4 or 5 different questions in there. And oh, there's Paige. Oh, you're unmuted now, Paige. Hi. So more likely to contract so in each of these things, we don't really know. So we're a little bit going on theory and best guesses. More likely to contract the virus, the answer is probably no. More likely to be, really, I think what people are really worried about, like I have some dreams where I would like to get infected. I would just like to get the guarantee that I'm going to do absolutely great, and 2 weeks from now, I'm done with it. I'm making IgM and IgG, and I can go to the supermarket with the young people. You know, that's one of my goals in life now. More likely to be critically ill with the virus is, I think, what we're all worried about. Not so much would we get infected as are we going to get extremely sick. And a 12-month-old statistically is likely to do really well. Not 100% guarantee, but there actually have been very few infants who have died from coronavirus. So it's certainly not a guarantee, but we don't think that there's a huge excess risk. But the only thing we can do right now is prevent, because we don't have a medication that's available for a 12-month-old. And we know that once you get to the stage of a ventilator, whatever age you are, the mortality is really high. From the point of view of what to do, I think we're all doing a lot more telephone communication and telehealth visits. And I think you should call and see if your physicians will do a visit with you, you know, via telehealth. The insurance companies, after resisting telehealth forever, have mostly, at least in our neighborhood, have mostly all said, you know what, they will save money if their patients get good care and don't get infected. And so they've said that they will pay. We don't know what they'll pay, but they've opened it up so that your coverage should cover you for those kind of visits. And so since we can't bring people in and we can do telehealth, and you know, there are a huge number of businesses in the country that are dying or some are dead. But most of the hospital systems also are getting killed. I mean, our hospital's revenue is down 60% every day from baseline. We're not going to die. We're still going to be around in a year. We're committed to it. But, you know, for a lot of people, if they can't do telemedicine, they're just kind of sitting around. And so I think you could get good quality telemedicine. Everybody is ramping up and learning how to do it. And for the most part, you can get a good discussion. And I actually think for a lot of physicians and nurse practitioners, you can spend more time, you know, on a video visit than you do sometimes in the office. So I would encourage you to do that. And certainly at that age, if the itching is increasing, the medical options are increased there as well.
And Terry Dell has a question, another question.
Thank you.
Hi. So my question is more general, not necessarily COVID related. So our son has the pulmonary stenosis where all the arteries and as they diffuse into his lungs are too small. And when he was 1 year old, we went to Texas. Dr. Frazier did a surgery to open up those arteries as far as he could reach. Now that he's 8 years old, we're starting to see those numbers, his systemic pressure creep back up. And was wondering if you knew of anybody that is working on a different solution or you know, any hospitals or doctors that are working on that. Also, I think, didn't I have another one? Anyways, I'll let you answer that one and I'll remember my second one.
Yeah. So the need to treat that depends a lot on how high the right heart pressures are. And sometimes that can be done in a cardiac cath lab. And there are different techniques. And sometimes it needs more advanced techniques. I think one of the real leaders in this in the country is Stanford in California. They are really great at this. But a lot of the really big heart centers do this kind of work now and do it well. There's always the risk and benefit. We talked about that with vaccines. But when you balloon open an artery or when you put a stent in an artery, you are trading kind of one disease for a different disease. And so you have to be sure that the thing that you're treating is really limiting function, and you're in a good place. So I'm sure that they know what they're doing with that. A lot of people have a really loud pulmonic stenosis murmur, but it doesn't stop them from running track, you know? So that's an important thing to really sit and say, you know, do we really need to go this next step? And what are our risks and what are our limitations?
Yeah, so yeah, you wouldn't know. He goes and goes and goes. We have done the ballooning. They tried ballooning. He didn't get any result from it. My second question is his liver numbers are also starting to creep up. And I know that they were looking into the fact that he might be becoming immune to ursodiol or different things like that. We've tried the rifampin and all of that. Do you know of any other therapies or anything? He has a biliary diversion drain, an external one.
Yeah.
So that helps with the itching and everything, but it's not stopping his numbers from creeping up.
The numbers, if you mean the ALT and AST, the numbers by themselves are not too important compared to all the other things. So, you know, there are a lot of patients who have ALT and AST that are 200, 250, and that's what they are when they're 5 and when they're 10 and when they're 20 and when they're 25, and they still have their own liver. So if the albumin is changing or if the PT is changing, those are higher importance numbers. I think we remark on the ALT, but it doesn't drive therapy very much. On the other hand, if the itching was increasing, that would be unusual at this age with a diversion, and that would make us think about other things.
Awesome. Thank you.
Well,
Okay, does anyone have any other questions? Just go right ahead. Spit it out.
but you're all on mute.
Okay, I have a question. Shocker. So moving forward, just kind of so moving forward, kind of a rule of thumb, should we just always take into consideration that our kiddos, you know, even if they do or do not seem to have extenuating or excessive issues with their heart or post-transplant or anything like that, should we always just kind of assume that, I'm trying to ask a question, you crazies, that we have to listen to whatever, good Lord, that when we have to listen to whatever guidelines our statewide and transplant team is suggesting for the higher risk people? I don't even know if you understand me now, because
I think transplant is its own issue, whether you're transplant for Alagille or transplant for biliary atresia. It's just that transplant for Alagille is much more complicated because they have to think about, for instance, the kidney that's in there that is an Alagille kidney supporting a transplanted liver. So you definitely want to listen to the transplant teams. They have a good idea about things. You know, we have our own, I would say, set of things that are special for Alagille. We believe Alagille or biliary atresia, if you have a big spleen, you should have a spleen protector. And we make a great spleen protector that it's not perfect, but it's, you know, kind of bulletproof. We believe that kids should not do sports that cause impact to the head. You know, I love soccer. I don't love soccer for Alagille, because no matter what you tell the kids, they're going to ram their head into each other and into the ball. And we think that that is a risk. You know, fractures of the long bones, you know, is another thing. So there are special things, some of which are transplants, some are not, that are things that I think you do need to think about. Extra nutrition, vitamins, those sorts of things. Obviously, I think at this point go without saying.
We have some families right now, Dr. Piccoli, that are just approved to go on the transplant list, and they're doing their evaluation appointments, and they are scared, especially during this time. Any words of encouragement for them, or advice? You know, we have one family in particular that really comes to mind in California, where the dad is going to be possibly a live donor, and you know, they're going to separate hospitals and coming back, and they're being tested for COVID, and you know, there's a fear behind that, and there are several other families just now getting on the list. Anything that you can say to, you know, put their mind at ease during this strange time and going through one of the biggest changes of their life?
Yeah, well, I mean, obviously it's a really important time. During the evaluation, you and your family are the same as you were, you know, 2 weeks ago, 4 weeks ago, before you made the decision. And a feature of Alagille syndrome is that you rarely have to make a decision on one day. You know, you get to talk about it for a while, you gradually drift into it. There are other kinds of liver disease where you're fine, and 2 days later you're in a coma, and 2 days later, if you don't transplant, you die. I think that as you're getting, so for a living related family specifically, I would go into like deep isolation, you know, 2 weeks before the transplants. But we did 2 transplants last week. You know, we check the staff who are involved with the transplant. We check the patient and the parent. And something just happened. I don't know what. But you know, you
Someone
could.
is sharing their screen.
Ah. Okay.
Hey, there you are, twice.
And is there a way that I can unshare that, or? Oh, it suddenly is all in Spanish. My entire screen. Oh, somebody did it. Okay. So, you know, there are safeguards, and I really feel that although we're being extraordinarily careful, the hospital is one of the, once you have good testing, the hospital is one of the safest places you can be, because you know. So I think it shouldn't interrupt the sequence. Obviously, if you found out you were coronavirus positive 2 days before a living related transplant, you would just cancel it. You'd postpone.
And any other questions? Ask while we've got him.
I have one more if you really do have a minute of time.
San Antonio.
Yes, we're already at 94 degrees on average here in the day, and I'm jealous of you guys up north. So Diana, for about 18 months now, has consistently had high blood pressures, like 160 over 80-ish, and so she's been away from nephrology for a good 6 years now, and we're being routed back into nephrology consult on that because of the blood pressure, but we won't have, our old nephrologist moved to Kentucky several years ago, so we're getting a new person who's never seen an Alagille's patient. Is there anything in particular I should say, ask, point towards, anything like that?
Yeah. So you should just walk in and say, I need to know, is there renal artery stenosis or not? In all seriousness, we have a kidney paper. Kamath is the first author. You can download it. And you should kind of bring it in and say, you know, no nephrologists have ever, you know, seen this. This is what we're worried about. The nephrologists know what to do with hypertension. And the thing that is different is a number of Alagille patients have, well, almost all patients have narrowing of the blood vessels coming from the right side of the heart. Some have narrowing from the left side of the heart, like coarced, but a number of patients have narrowing of the kidney arteries. And that kidney artery narrowing causes super high blood pressure. So that would be one of the first things to think about and look for. And you can help them. You know, I always feel that if you help your doctor look good, they'll look better. So having that paper and saying, you know, I know that one of the special problems of Alagille is the artery that goes into the kidney, you know, and what else should we be thinking about? Sometimes I think we've lost the Gaffords, but your pediatrician could order a renal ultrasound with Doppler, and you could walk into that with one of the answers.
Okay, she had that done ordered by urology 2 weeks ago, because we've still been seeing urology, we just haven't seen urology. So
Do you know the results?
So we had the follow-up with the urologist.
Yeah.
But
okay.
he just, nothing remarkable. So
that's good news. Yeah. Good.
Okay. Thank you.
Mm-hmm.
Dr. Piccoli, can you speak to Moya and Alagille?
Sure. So Moya is narrowing of the big blood vessels that perfuse the brain. And some of the things in Alagille syndrome are present at birth, and some of the things develop with time. And Moya is one of the things that develops over time, just like sometimes the pulmonary arteries change over time. And so it's something that we believe is very important to think about and screen for. Certainly if you have headaches or neurologic symptoms, but we really believe that, you know, in the early mid-school age years, people should get a head MRI and MR angiogram once they can do that without general anesthesia, to look at those blood vessels, because there's a very surprising operation that can be done that perfuses the front part of the brain if you have moya moya. Everybody knows you have an artery that, you know, it's kind of like you feel it in your temples, it pulses, and a neurosurgeon can plant that artery onto the brain and perfuse the brain in a procedure that's called synangiosis. So it can be treatable, and if it's not treated, it's really a critical blood vessel abnormality. It doesn't just happen in Alagille syndrome, it happens in some other diseases, but it's really, really important. And we have a couple of vascular papers that describe this, and we think it's one of the rare but very important later complications.
And along the lines of moya moya, would you say that there's a standard, a gold standard for having MRIs, whether it's baseline MRIs? This has been a question that we get very often from our families. What do you say about, you know, how often people should be getting them, where they should be getting them?
Yeah. So this is an area where, I mean, a number of us believe that there should be a baseline MRI that's done if you have any neurologic symptoms or sort of in those early school age years. Insurance companies deny it sometimes. A number of people don't agree with that recommendation. There have been times where we've found an old stroke or an aneurysm, things that matter, early moya moya. And we think that we believe that it should be done on everyone, and it should be repeated at intervals. Not in the toddler era, but in, you know, the school age years. Not everyone agrees with that. Not everyone agrees that you shouldn't play soccer. And we had proposed to the federal government that we wrote a research proposal to try to study this and to make more formal recommendations. And, you know, one of the problems with MRIs or MRAs is that they're extraordinarily expensive. And the study, although I think we all thought it was a great study, was not funded. We think that it is prudent, and it clearly sometimes picks up things. But the other thing is, if you had a stroke when you were 2 and you're fine, and then you have a head injury and somebody does a CAT scan in the emergency room, and suddenly you're thinking, oh my goodness, this is brand new, it would be so much better to be able to say, oh no, we have an MR, and when she was absolutely 100% fine, this lesion was there, so this is not new. And that's a really valuable thing to know. So we're pro. We don't say that the people who are anti are wrong, but we think that it has great value.
Okay, last question. I'm gonna ask you to get to the emotional heart of some things here. All these families, some are new diagnoses, some have teenagers that are having a difficult time. We have some adults here. We see a lot of families that are dealing with guilt for whatever reason, whether they have Alagille and they feel guilty that they've passed it down, or they can't, you know, feed their child, or you know, they're struggling in one way or another. How do you address this in the clinic? What do you tell the parents that are feeling anything like this? What are some words of encouragement for these families that you have here today?
Well, I think first of all, you know, we all have genetic things, sometimes that our parents had and gave to us, and sometimes that are new in each of us. And the feeling of guilt is understandable, but it's not really rational or justifiable. You know, these are things that happen, and they didn't happen because you did something before pregnancy or during pregnancy. But I think that's really hard, because we all love our kids and want our kids to have you know, a life free of as many challenges as we can possibly give them. We have a whole team of psychologists that help us with these things and help us with the struggles that you have every day watching your child suffer, or you know, fighting with them because you know what is the right thing to do and they're not on board with it. So I think it's really tough, and I think that you know, professional help is available, hopefully in every place, certainly in a lot of places. And I think the families can become really strong, and the kids who surmount these challenges are really extraordinary. But there are a lot of challenges, and it's really difficult. And sometimes, you know, something like the Alliance, where people can get together and say, you know, this is really, really tough. You know, as you can imagine, you know, your first child is sick, your second child is sicker, and it can just be overwhelming. And sometimes you have to be able to say, this is overwhelming, I need some help. I do think that there are a lot of things at the national level and at the state level that could make things better. You know, healthcare for kids is at a state level. I feel kind of lucky we're in Pennsylvania. Pennsylvania is good to kids. We're surrounded in states that it's very hard to get basic things. I mean, why, you know, is it so tough to get vitamins? It's enough of a challenge to get them into somebody, but why should they be so unbelievably expensive? You know, why are they not covered? There are a lot of those kind of challenges that could make life easier, that we as a society should really think about. And you know, Medicaid is definitely not perfect, that in some states it's really horrible. There's so many of those kinds of burdens. The school could be better, you know, the peer group could be nicer, you know, all those different things. And I think we keep trying to solve those things. We're definitely not perfect at doing all of that. I think we as caregivers admire the families with Alagille syndrome, because they do a tremendous job and surmount an incredible number of challenges, and should really be congratulated for that and supported.
Thank you so much for coming on this call today. We're just so grateful, and we, you know, thank you so much. If any of you have further questions, you can email those questions to alagille@alagille.org, or my email, Roberta, ROBERTA @alagille.org, or Cherbork at CHER.BORK and we will get these questions, continue to give them to Dr. Piccoli, and we'll get with him to schedule another Zoom in the future, and hopefully in the near future. And you know, remember that the Alliance is here We have resources and an assistance program, and we're very knowledgeable about Alagille as well. We can answer a lot of your questions. We have partnerships with some of the pharmaceutical companies that are working on the itch drugs. You know, we can help you as well. And then those things that we can't answer, you know, we've got wonderful, wonderful experts like Dr. Piccoli, who we turn to and rely on for answers. So please don't hesitate to reach out to us as well. So thank you all for coming.
Thank you so much, guys.
Good luck, everybody.
Thank you.
Thank you.
Thank you.
Thank you so much.
Bye, guys.
Bye.
Bye.